Hello, my name is Anna. I'm an education coordinator with the BC Centre on Substance Use. Thank you for joining this session. Today, we are sharing an overview of the fentanyl tablet prescribed safer supply protocols with considerations for the off-label use of fentanyl tablets to reduce unregulated fentanyl use and associated harms. I'll introduce the speakers in a moment, but first, I would like to respectfully acknowledge that the land on which we work and that we're hosting this session is the traditional unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. We recognize that the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harm Indigenous peoples, and that continuous efforts are needed to dismantle colonial systems of oppression. We see our work as connected to these efforts and hope that the BCCSU contributes to an addiction system that provides safe, respectful, evidence-based care. I'd also like to note that many folks are joining from around BC and perhaps beyond, so I encourage you to take a moment to reflect on the lands that you are on. So I will now pass you off to our first speaker to introduce herself. This is Kelsey Roden, so thank you so much.
Great, thanks, Anna. So I'm Kelsey Roden. I'm a family physician here in Victoria. I'll be doing the first part of the presentation today and then handing over to Sarah. I finished the BCCSU Addiction Medicine Fellowship in June of 2020, and since that time, I've been working primarily in addiction medicine. For this presentation, my most relevant work is with Safer Victoria, where we have been doing Fentora prescribing for about 2 years now. I do not have any commercial interests or conflicts of interest to declare. And Sarah, I'll pass it over to you.
Hi, my name is Sarah Foster. I'm a nurse manager for research development, policy, and innovation at PHS Community Services Society, and I help to develop the policies that we use at Safer in Vancouver. I also have no relationship with commercial interests and no conflicts of interest to disclose.
Great. So by the end of the session, you will be able to describe the background and context of fentanyl tablets as prescribed safer supply. You will identify who may be good candidates for fentanyl tablet programs. We'll talk about 2 different dosing strategies, both a fixed dose PRN program as well as the maintenance program. We'll discuss how fentanyl tablets are initiated, administered, and assessed. We'll talk about the roles of prescribers, nurses, program directors, pharmacists, peer support staff, outreach workers in fentanyl tablet programs. And we'll compare the potential service delivery models and operational considerations for fentanyl tablet programs. I'll just let you have a look at the agenda before we move on. We can do the next slide. So fentanyl tablets as harm reduction are part of the provincial policy direction, which was first published in 2021 in order to enable access to prescribed safer supply in BC. This protocol is a harm reduction measure to reduce reliance on the toxic and unregulated opioid supply among people at high risk of drug poisoning death. Providing fentanyl tablets to reduce harms associated with unregulated opioid use is not yet an evidence-based intervention, so we don't have evidence to support it as an intervention, the safety data, or established best practices at this time. However, prescribed fentanyl tablets have been utilized in program settings in BC through PHS, AVI Health and Community Services, Safer, and Insight, and evaluation of this intervention is currently underway at these locations. So with that in mind, these protocols are informed by current clinical practice, as well as emerging evidence from these programs in order to provide considerations and guidance for off-label use of fentanyl tablets to reduce unregulated fentanyl use and associated harms. Fentanyl tablet programs can be integrated into existing programs and services, which could include prescribed safer supply programs, OAT programs, and that can include both oral OAT with methadone or slow release oral morphine, as well as IO programs. Of note, co-prescribing fentanyl tablets with buprenorphine is not typically recommended because buprenorphine could induce withdrawal symptoms in patients who are on fentanyl tablets because of its high affinity for opioid receptors, as well as its low intrinsic activity. Fentanyl tablet programming is could be well integrated into drug poisoning prevention sites and supervised consumption sites, or any combination of these types of scenarios. As with all substance use care plans should be individually tailored to each client's situation's needs and goals. However, access and adherence to OAT is not required for fentanyl tablet programming. So there's two main streams for program models as far as fentanyl tablet prescribing goes. The first is a fixed dose or PRN program, and this is done using 800 microgram doses every 3 hours, which could allow for up to 4 times daily dosing after an initial test dose and post-dose observation is completed. So this approach might be more desirable for patients who have lower opioid needs, who do not want to undergo a titration or missed dose protocol, for folks who have higher accessibility barriers, or for folks who have more episodic needs. The second option is a higher dose maintenance program. So this does require titration to achieve a scheduled maintenance dose, which is higher than the 800 micrograms. The approach might be ideal for folks who have higher tolerances. There is no maximum dose in the protocol. It's determined by the participant's comfort as well as any sedation post-dose. Medication dispensation can happen in a few different contexts. It could be done through a clinic that a participant attends to up to 4 times daily to receive the medications and any other care they might be eligible for. It could also be done where the participant titrates at such a clinic, but then once they've reached a dose which is sufficient for their tolerance, as well as no post-dose observation, no difficulties with post-dose observation, no sedation, then that participant could be transferred to a pharmacy for ongoing daily witness doses. And then lastly, take-home doses could be considered depending on clinical judgment, participant preference, and meeting eligibility criteria. And we'll talk a bit about that criteria towards the end. As far as eligibility for starting the program, the following considerations should be included. What the patient should have an opioid use disorder diagnosis, as well as ongoing active unregulated fentanyl use, as well as be at high risk of drug poisoning, injection-related harms, or other harms related to unregulated use. So a detailed assessment, including drug poisoning history, should be obtained. There might be some individuals who have not been diagnosed with an opioid use disorder, but who do use unregulated fentanyl and might benefit from accessing prescribed safer supply. In such cases, the PRN program could be a really good fit. It's not a requirement, as mentioned, to have trialed OAT in order to be eligible for this program, but prescribers should explore all options, including OAT options with participants. Contraindications to fentanyl tablets would include no history of opioid use, evidence of opioid non-tolerance, so this could be negative urine drug tests, no past history of OAT, or no documentation of witness consumption. As well, opioid use disorder, but without fentanyl use would be a contraindication, and so the intake assessment should include a detailed assessment of what participants are actually exposed to. Other contraindications would include hypersensitivity to any ingredient in the formulation, any disabling medical or mental health conditions which would preclude safe participation, and examples could be acute respiratory depression, a severe acute head injury, or current or recent monoamine oxidase inhibitor use. And then lastly, inability for the participant to provide informed consent would be a contraindication. Of note, pregnancy is listed as a contraindication. However, there could be exceptional circumstances where the intervention would be appropriate for a pregnant person. In such cases, two-prescriber review would be highly recommended, and one of those prescribers should be a perinatal addiction specialist. There are a few areas of caution for prescribing, and those would include youth who are 19 years of age or younger, participants who are actively using benzodiazepines, alcohol, or other CNS depressants, and note that benzodiazepine use could be intentional or unintentional. Also of note, the use of alcohol or benzos shouldn't result in automatic disqualification, but it should prompt further assessment. Certain ARV medications could be, or is an area of precaution, and we'll talk about that. And there's also a fairly long list of drug interactions, which we'll talk about, and there are detailed assessments, or sorry, detailed information in the protocol to help prescribers navigate that safely. Clinical frailty could be an area of caution, as well as driving. So participants who are initiating or increasing doses should not be driving or operating heavy machinery. Here's a basic list of drug interactions to be aware of. We're not going to go through all of these today, but just know that there is a detailed section of the protocol which includes interactions and what to watch for. So individuals who are on any of these medications should be monitored more carefully if they're initiating fentanyl tablets. And I would encourage prescribers to have a look at the protocol information before starting patients on these. A special note about ARVs, there is a strong interaction between some ARVs, specifically cobicistat and ritonavir, and any fentanyl products, including unregulated fentanyl. The issue is that it can lead to significant increases in fentanyl levels or serum levels of fentanyl in the patient's bloodstream. And so because of that, folks who are on ARVs need to be titrated a bit more slowly and monitored more closely for sedation. Also, because of that, it's not recommended to start fentanyl tablets in participants who are often stopping and restarting their ARVs because the serum concentration is less predictable. And if it comes to a discussion of altering the patient's ARV regimen, an HIV specialist should always be involved. So fentanyl tablets do require special authority. And then once that's approved, coverage is available through PharmaCare, Plan G, or Plan W. Before the protocol is actually started upon, there is a pre-initiation checklist to go through. So discussion and documentation with informed consent should be included. And that does include a discussion around potential risks and benefits of prescribed fentanyl tablets, as well as discussion of the absence of evidence in supporting this approach, the fact that it's a somewhat experimental approach, and discussion of continuing care and harm reduction education. The pre-application checklist could be completed either by a prescriber or by a non-prescriber who's a regulated health professional working within their scope. And as part of the initiation discussion, the participants' goals should be included so that areas of benefit and what to watch for as far as treatment success is included in further discussion in a tailored way for that participant. It's recommended to have two-prescriber approval. One prescriber would usually conduct the intake, and then a second would review the chart and sign off on the fentanyl tablet initiation. Two-prescriber system is a way to help ensure patient safety, but it's not possible in all treatment settings, and it should not delay initiation. For participants who are under 19, a two-prescriber approval is strongly recommended. And if you're working in an area where two prescribers are not available, then the 24/7 line could always be used as part of that process. Okay, we're going to spend a bit of time talking about the fixed dose protocol. So initiation on the fixed dose protocol is done, well, for either the fixed dose or the maintenance program, fentanyl tablets are administered buccally or sublingually. For the fixed dose protocol, the initial test dose is 800 micrograms, followed by a 25-minute post-dose observation. And then if the participant's safer sedation scale, or sorry, score is greater than 2, then they are ineligible for the program, meaning that they were too sedated after the test dose. If there's no sedation after the first dose, then they can continue on 800 micrograms every 3 hours as their fixed PRN dose. This is what the safer sedation scale looks like. So as you can see here, scores of 3 or more would be considered too sedated for ongoing doses and therefore ineligible for the program, or at least for ongoing titration. In the case of the PRN program, then if they can't tolerate the 800 microgram dose, then they would be ineligible for ongoing doses. The participant must continue post-dose observations for a total of 4 doses over 4 consecutive days, including that initial test dose. So they can stay for all 4 doses in one day. They can have 2 doses over 2 days, or they can have 1 dose in 4 consecutive days. After the 4th day, if the participant has no complications and no sedation, then there's no further post-dose observations needed. The prescriber can always make clinical judgment on a case-by-case situation to stop post-dose observation as long as the participant remains in the PRN program without triggering a missed dose protocol. Participants might choose to switch to the maintenance program at any point in time, and we'll talk about how to do that after the next steps. Regarding missed doses during the fixed dose PRN program initiation phase, if any doses are missed during initiation, the participant must continue with post-dose observations until 4 observed doses over 4 consecutive days are achieved, and there must be no sedation 25 minutes post-dose. For missed doses on the PRN program after initiation, if the participant misses 10 doses, then the clinic, pharmacy, or prescriber must pause the prescription and assess the participant and contact the pharmacy to restart that prescription. If the missed doses are between 60 and 178, then a reassessment should be conducted, including vitals, point of care UDT to confirm tolerance, as well as an assessment of their unregulated opioid use. So if the participant is reporting no unregulated opioid use in that time, they should restart the program at initiation. But if unregulated opioid use is present, then you could just restart it with a test dose plus 25-minute post-dose observation. And if it's more than 179 missed doses, prescribers should assess participants in person to determine if they're benefiting from the program or not, and potentially to explore other options. So we'll talk a little bit now about the higher dose maintenance program. Just like with the PRN program, tablets are buccal or sublingually administered. The tablet should dissolve within 14 to 25 minutes. Participants should also be instructed not to split, suck, chew, or swallow the fentanyl tablets. They really just have to sit against the mucosal surface and dissolve. It is recommended that participants alternate sides of the mouth when they're administering subsequent doses of tablets. The higher dose maintenance program does require titration, and that's why it could be preferred by participants who need doses above 800 micrograms. During the initial titration phase, participants do need to attend the clinic or the site at least twice daily. The initiation phase should be followed by a period of post-dose observation once they've achieved their maximum dose in order to establish tolerance and safety. So i.e. that's the 4 observed doses over 4 consecutive days. There is no maximum dose for this program, and all participants should be titrated starting from 800 micrograms until an effective dose is reached. It is recommended that participants are given the tablet combination using as few tablets as possible. The reason being that there's very subtle differences in absorption between single tablet administration and multiple tablet administration. Regardless of baseline opioid use, the initial dose is still 800 micrograms. A 25-minute post-dose observation is required after each dose during this initiation period. If there's no sedation after the initial dose, the participant can access an additional 200 micrograms if they'd like, followed by another post-dose observation. And if there's no sedation after the first doses, so either the 800 alone or the 800 plus up to 200, then the participant might begin their titration starting at 800 with a minimum of 3 hours between doses, and then increasing of 100 micrograms each subsequent dose. Post-dose observation of 25 minutes are required after each dose during initiation. So this is what an example protocol could look like. Based on the hours of operation and program capacity, participants could access twice daily, 3 times, or up to 4 times daily dosing. And then once the participants' cravings and withdrawal symptoms are managed, that dose is considered the maintenance dose. So this table details the missed dose protocol for participants who are in the high dose maintenance program during the initial titration phase to maintenance dose, or if they're restarted after an extended absence. If the participant has missed 2 consecutive doses, there's no change and they can continue with the next step in titration. But if the participant has missed 3 or more doses, titration should be restarted from the beginning. So this image details the missed dose protocol in the high dose maintenance program during the maintenance phase, i.e. when the participant has reached maintenance or 4 consecutive doses without sedation. All dose adjustments at this point must be made by the prescriber. And of note, post-dose observations are always resumed when participants are titrating. If they had previously achieved 4 post-dose observation periods across 4 consecutive days without sedation, there's 1 post-dose observation after reaching maintenance. And if at that point there are no complications, then the participant could continue with no post-dose observations. However, if they had not previously achieved the 4 post-dose observations across 4 days, then they must achieve that at maintenance without sedation. The prescriber can always make clinical judgment on a case-by-case basis of when to stop post-dose observations. This missed dose protocol applies to individuals who previously reached either maintenance or 4 post-dose observation periods across 4 days without sedation, for individuals who had a 25 to 50% dose decrease due to missed doses, or for folks who missed 1 or more doses during the retitration phase. So in this point in time, if the person has 1 to 6 missed consecutive doses, then they would just continue with the titration as written. If they have 7 missed doses, they repeat the last dose received. And if there's 8 to 17, then they decrease the dose by 50%. If a participant is scheduled for a dose increase the following day, they may miss up to 4 doses and still receive that increase. However, if they miss 5 to 7 doses after a scheduled increase, they should return to their previous dose before continuing the titration. And then if they miss 15 doses, they require 1 post-dose observation as per the missed dose during maintenance protocol. Regarding initial and ongoing assessments, initial assessments should be done prior to starting the program. The assessment may be completed either by the prescriber or by a regulated health professional who's working within their scope. The prescriber should, however, be consulted if there's any concerns brought up by the initial assessment. And then both initial and ongoing assessments include subjective and objective measures. Subjective measures might be how well the current program is supporting patients' goals, what their substance use is since the last visit, drug poisonings, etc. Objective would typically be general appearance, signs of intoxication or altered level of consciousness, urine drug screen, vitals, etc. Ongoing assessment should occur around every 2 months, depending on the clinical context and capacity. Assessment of clinical and psychosocial indicators would be included, as well as participant goals, and it should be performed to determine if the participant is benefiting from the intervention. If the participant is not benefiting from the intervention, clinical judgment should guide the treatment plan, and adjustments could include things like increasing the fentanyl tablet dose, co-prescription, or increasing their OAT dose, increasing psychosocial supports, or potentially stopping the intervention. Pre- and post-dose assessments both include subjective and objective measurements. Post-dose assessments will also include the dose and time that it was administered, as well as when the next dose is due and any follow-up or referral information needed. There are situations where a dose might need to be held. If it's determined that it has to be held, then this should be documented very clearly, as well as discussed with the participant. The participant should be allowed to return within a few hours for reassessment to see if they are at that point in time able to receive their dose. It's important to offer education to the participants so that they understand the risks of combining fentanyl tablets with other medications or with unregulated substances. And there are situations where oral OAT doses have to be adjusted or held, and this can simply be following the guideline for clinical management of opioid use disorder per BCCSU protocols. Take-home doses might be available for patients depending on certain criteria. Specifically, if the person has completed titration, if they are displaying psychosocial and clinical stability, if it's their preference, if they're able to safely store doses, and based on clinical judgment. Operational considerations might necessitate take-home dosing. However, it alone should not be used to make that decision. You have to include the other considerations as well. Participants are encouraged to provide point-of-care urine drug testing within 2 weeks of starting a program, but it could be waived based on clinical discretion if the participant is very well known to the staff, if there's objective evidence of fentanyl use, or if there's sufficient collateral. And then the decision, if it is made to be waived, has to be documented or should be documented. Participants should provide a UDT around every 2 months for ongoing monitoring. It should also be done for participants who have been away from the program for more than 30 days in order to help provide evidence of ongoing tolerance. If a UDT is positive for other substances, this is not a reason to discharge someone from the program, as they might be experiencing other benefits such as decreased unregulated use, OAT titration, and then housing or other signs of stability. Confirmatory testing should be done for benzodiazepines, specifically atizolam, because it can provide additional information both for the participant as well as for staff. And there are times where the fentanyl tablet program may need to be discontinued. If individuals are choosing to discontinue the fentanyl tablet program, then transition to oral OAT and other treatments should be offered. If they wish to transition to oral OAT and stop tablets, they could do so at any point in time. During OAT titration, the tablets could be tapered or stopped depending on the participant's discretion if cravings and withdrawal are adequately managed. If transition to other programs or treatments is required due to repeated diversion, participants who are currently on tablets alone and are being discharged should be offered standard oral OAT according to BCCSU guidelines. Participants who are on tablets and OAT together and are being discharged from the program should still be continued on their OAT dose, and that dose might need to be increased as well. Okay, I will pass this off to Sarah to talk a little bit more about assessment.
Thanks, Kelsey. So for assessment, continuing care, and program evaluation, Clinical experience has found that it takes on average 3 to 6 months to determine if a participant is benefiting from the Fentora program. Example clinical indicators that the participant is benefiting include reduced concurrent substance use, reduced reliance on the unregulated drug supply, and reduced visits to the emergency department. If there's no change or an increase in any of those, it indicates that the participant is not benefiting from the intervention. Example psychosocial indicators that the participant is benefiting may include gaining employment, reconnecting with family and friends, and attaining housing. And if there's no change in employment, no change in reconnecting with family and friends, or no change or loss of safe housing, it may indicate that the participant is not benefiting from the program. Program evaluation measures that can be used to help assess benefit include the amount and frequency of substance use, the frequency of drug poisonings, frequency of emergency department visits, severity of cravings and withdrawal symptoms, urine drug test results, and participant self-report. So for service delivery models, service delivery models should take into consideration resource availability, local engagement, consultation with people who use drugs, local cultural practices, and program-specific strengths and constraints. Innovative approaches and considerations are needed, particularly to support rural and remote areas. Examples can include clinic and site exclusive models, mixed clinic and site models, and community pharmacy, mixed clinic and outreach models. This list is not exhaustive, but a prompt to tailor programs to fit a community's unique needs. Program operations will depend on resources, prescribers, and nurses. Programs are encouraged to build clinic flow and program-specific protocols based on staffing available. Sites that offer supervised consumption services, overdose prevention services, IOT or TIOT, tablet injectable opioid agonist treatment, are best situated to offer this program. Hiring people with living experience or peers as support workers and system navigators is considered best practice and can help build trust with participants and increase program engagement. Assessments, titration, and maintenance doses are conducted by nurses. Operational logistics and considerations. Nurse-led programs may include nurse-led titrations, which would include a titration ceiling, and any doses beyond the ceiling may require prescriber assessment. And nurses contact prescribers for new prescriptions or changes in prescriptions. So for pharmacy-based dosing, participants complete their post-dose observation requirements and the prescription is transferred to a participating pharmacy and subsequent doses occur in the pharmacy. Pharmacy-based dosing is dependent on pharmacy capacity and the ability to accommodate, and mixed pharmacy clinic options may reduce barriers for folks. So role of healthcare providers. There are multiple roles for prescribers in fentanyl tablet programs. These roles include, but are not limited to, the following. Prescribers approve participants to enter the fentanyl tablet program. A two-prescriber approval system is highly recommended. Prescribers conduct pre-initiation assessments and ongoing clinical monitoring. Prescribers write prescriptions for participants and provide new prescriptions for dose adjustments if a participant experiences sedation and dose increases. Nurses have multiple roles in the program, including pre-initiation assessments, pre- and post-dose monitoring, and ongoing clinical monitoring, and titration and maintenance doses may be administered by nurses. And pharmacists and pharmacy staff play an integral role in the supply, delivery, monitoring, and reporting of medication, including contacting the prescriber if a participant has an extended absence from the program and wants to restart. Pharmacists may observe doses and conduct post-dose post-dose observations if required. And I'm going to pass it back to Anna now.
Thank you both. That was great for walking us through the Fentora tablet provision protocols. So if you would like to view those protocols and any other resources, they are on the BCCSU website at www.bccsu.ca. And so we have released the Fentora tablet provisions protocol, as well as a guideline for clinical management of opioid use disorder will be re-released in the fall, early fall, late summer. And we also have the BCCSU urine drug testing in patients prescribed opioid agonist treatment. And if you're a clinician that's providing substance use care and you require any additional specialist support, the BCCSU is now offering an addiction medicine clinician support line. This line is 24/7, 365 days a year, and it will connect you to an expert in addiction medicine who can help you walk through any challenging situations that you may find in your practice. So please feel free to use the phone number provided on this slide. And for more information, please visit the BCCSU website. And that's it. Thanks so much for attending, and we hope you got some use out of this presentation.